Hi, welcome to another episode of Strive Sessions. I'm Megan Kilcarey, one of the clinical liaisons with Strive Pharmacy. Today, we're going to be talking about women's health. This is definitely a subject that is near and dear to all of our hearts here at Strive Pharmacy. So we're going to talk a lot about bioidentical hormones, what they do in the body, and how they can benefit your patients. So first, a disclaimer. This presentation is for educational and informational purposes only and is not intended as medical advice, diagnosis, or treatment. These statements have not been evaluated by the U.S. Food and Drug Administration. Compounded medications are prepared for individual patients' needs based off of a valid prescription from a licensed healthcare professional. Strive's compounded medications and supplements are not reviewed or approved by the FDA to diagnose, treat, cure, or prevent any disease. This information shared is based on current literature and clinical experience. Individual patient care should always be guided by a qualified healthcare professional. While clinical data exists for FDA-approved commercial products, compounded products are not FDA-approved and have not been studied for safety or efficacy. Potential benefits apply to the specific ingredients and may not necessarily apply to a combination of those ingredients. Any experiences or outcomes mentioned do not indicate or guarantee similar outcomes for all patients. Individual experiences and outcomes may vary. So on our agenda today, we're going to go over an introduction to hormones. We're going to talk about perimenopause and menopause, advantages of compounded products, and we're also going to go over several different hormones such as estrogen, progesterone, testosterone, DHEA, and how they interact and work within the body. So, an introduction to BHRT. BHRT stands for Bioidentical Hormone Replacement Therapy. So what are bioidentical hormones? These are the hormones that are designed and molecularly identical to the hormones that our body naturally makes. So our body cannot tell the difference between BHRT hormones and what it would naturally make. The source of these hormones are often going to be plant-based. So they're either going to be yam or soy-based. All of the hormones that we use here at Strive are yam-based hormones, and they're synthesized in a lab, again, to match the body's own naturally produced hormones. So in contrast to synthetic hormones, these are traditionally non-bioidentical. So think of products like conjugated equine estrogens or medroxyprogesterone. These are not bioidentical hormones because, again, they are not the same chemical structure as what our body would naturally make. And so oftentimes, these non-bioidentical hormones can have different interactions within the body at the receptor sites than bioidentical hormones can have. As you can see here too, I have a diagram of the steroidogenesis pathway. So at the top of that pathway, we have pregnenolone. We call that the mother of all hormones. So all of our other hormones are synthesized down off of pregnenolone. So you can see we have progesterone coming off of that pathway. Then we get down to DHEA. DHEA can be broken down also into some testosterone. Testosterone is broken down into estrogen, and there are different types of estrogen as well. So this is one of my favorite pathways to go over, and something that I think we all learned about in biology and when we were in college. But as you can see, it's very important how all of these hormones interplay together and have a role as far as affecting the different systems throughout our body. So I'm going to talk a little bit about the Women's Health Initiative, and this had a huge impact on female hormones over the last few decades. So the original goal of the Women's Health Initiative, or the WHI, it was a large-scale NIH study, and it was to determine if hormone replacement therapy could potentially prevent chronic diseases such as heart disease, bone fractures, and dementia as women aged. However, the findings that were released in 2002, so about 25 years ago, showed that actually the hormones that were used in the WHI increased the risk of breast cancer, increased the risk of stroke and blood clots, and increased the risk of coronary artery disease. And so during the WHI, the Women's Health Initiative, the trials were actually stopped on hormone replacement therapy because they did find at that point that a combination of estrogen and progestins did increase the risk of all of these. So what happened? After the WHI findings came out, the use of hormone replacement therapy in women's health drastically plummeted. And so what we saw happen was a lot of women were suffering the effects of low hormones, like the vasomotor symptoms, the hot flashes, the night sweats, the brain fog, the dry skin, a lot of vaginal atrophy and genitourinary type conditions. And they were scared to utilize hormone replacement therapy because of the findings that came out from the WHI in 2002. However, luckily, over the decades, we have had some wonderful researchers that have made it their mission to study hormones and specifically bioidentical hormones, and have come back and shown that using hormone replacement therapy, specifically bioidentical hormones, did not increase the risk of breast cancer and blood clots and coronary artery disease. And so we'll get to that in a few slides here, but I think it's really important to circle back around and talk about the Women's Health Initiative and why there is such a stigma attached to hormones right now in this country. And so what has changed since the Women's Health Initiative? Well, again, we have done a lot of reanalysis on that original data. So a couple things. First, we have the timing hypothesis. So the original study's average age was 63 years old for female patients. However, most patients are starting menopause or perimenopausal symptoms in their 40s and 50s, and sometimes even in their late 30s. And now we know that for women who are under 60, there are huge benefits to starting hormone replacement therapy within 10 years of the onset of menopause. So, starting those hormones earlier definitely has an increased benefit to them and helps to outweigh the risks of a lot of those negative effects that we saw in the WHI. So in 2025, there was a landmark ruling by the FDA. In November, they removed the black box warning on many HRT products that are out there. And so the FDA has acknowledged that in 2002, the risks were overgeneralized for younger patients through that came out of the WHI. And so the outcome is that we've really destigmatized the use of hormone replacement therapy for patients. And it's important to note that we're making a return to evidence-based medicine and the fact that one size does not fit all. And again, so we want to make sure that we are personalizing medicine for every patient based off of their symptoms and needs, and not denying therapy for patients that need it just because of old data that came out 20 plus years ago. So another important thing is that formulation does matter. So the original study with the WHI was using oral medication. And so oral medication is going down and broken down through the liver. It's going through first pass metabolism. We're making different metabolites. And if you remember back to that original picture of the steroidogenesis pathway, when all of these hormones are broken down, they're broken down into different types of metabolites. Some metabolic pathways are safer. Some metabolic pathways can potentially lead to other complications. And so when we're taking oral medication, we do have to be cognizant of those potential metabolites that we are creating. However, we know that with topical preparations or transdermal type preparations, when things are going through the skin, they are not broken down through the liver through first pass metabolism. So we are potentially avoiding a lot of those negative metabolites that could be formed through the oral process. And so with topical, we do have a lower risk of blood clots. We do have a lower risk of other complications and potential for cancer risk than we do with the topical dosage forms. So it's also important to make sure, as time goes on and patients are utilizing these therapies, that the long-term benefits, we're reevaluating the data that's out there. And that's what was done over the last 20 years with the original WHI data. So important to continue to follow up on the results that are coming out. And And again, it's showing that utilizing HRT is really reducing all-cause mortality and significantly lowering the risk of osteoporosis, bone fractures, Alzheimer's disease, neurodegenerative disease in general in female patients. So I think what we are finding is very exciting overall for the long-term health of women when it comes to utilizing bioidentical hormone replacement therapy. So breaking down hormone replacement therapy then during the WHI and BHRT now. So some of the things we're talking about in the 2002 interpretation, hormone replacement therapy was generally discouraged and it was considered to be unsafe. However, the modern view of bioidentical hormone replacement therapy, it's recommended for most women that are under the age of 60, especially if they are symptomatic. When it comes to heart health, in 2002, it showed that the hormones that were used increased heart attack risk. However, we know that with bioidentical hormones, it can drastically reduce cardiovascular disease if it is started early. With regards to brain health, there was an increased risk of dementia with hormone replacement therapy. But again, with the bioidentical, we do see some potential for neuroprotection there. As far as the FDA status goes, we previously had a lot of strict black box warnings on those hormone replacement therapy products. And now, as of late 2025, those warnings were removed. And as far as duration goes, it was recommended to use hormone replacement therapy for the shortest amount of time as needed. And now that we know with the bioidenticals, it is very individualized and can be used safely, potentially, for long-term use. So going over some of the potential benefits of bioidentical hormone replacement therapy, certainly there is symptom relief and quality of life, which is huge. So addressing a lot of those vasomotor symptoms like hot flashes, mood swings, night sweats, certainly promoting energy levels, supporting sleep and healthy weight. From a physical and sexual health side of things, we see increased libido, help with vaginal dryness, supporting bone health, and definitely increasing lean muscle mass. And then going on to some of the neuroprotective benefits with regards to BHRT, hormones can support nerve cell growth and repair. Estrogen has anti-inflammatory benefits to it and can decrease the buildup of beta amyloid plaques. And then we also know that the critical window, again, for starting hormone replacement therapy is within 5 to 10 years of the final menstrual period. So again, we don't need to wait until, symptoms progress. We can start them early, and we know there are a whole host of benefits to starting earlier rather than later. So next we're going to get into perimenopause, and we're going to talk about the physiology of hormonal decline in female patients. So the menopause transition is marked by a fluctuation in ovarian function. And so progesterone deficiency is often the first hormone that we see start to decline in the perimenopause phase. And so this imbalance contributes to potential for estrogen dominance in perimenopausal women. So oftentimes, just some supplementation with progesterone alone can really lead to some drastic differences in the way patients feel and in symptom improvement for them. Also, estradiol levels can swing and be very unpredictable as well. Sometimes they run high, sometimes they run low. And a lot of these symptoms that women will experience during that perimenopausal phase, irregular menstrual cycles, early vasomotor symptoms, increased PMS-like symptoms, and definitely sleep disturbances are some of the most common things that we see during this phase. Again, and just some supplementation with a little bit of progesterone can often help to balance out some of those estrogen dominance symptoms that female patients will have. Progesterone can also help to balance out irregular menstrual cycles, definitely helps with sleep. It helps with that brain fog that a lot of women will start to experience as well. And so it's so important that we start to address these early symptoms that our patients are coming to us with. And oftentimes estrogen replacement isn't always needed in this perimenopausal phase. Progesterone alone can be life-changing for a lot of these women. So I tell prescribers all of the time to, don't forget our perimenopausal patients. And again, this can start as early as mid to late 30s for a lot of patients. One of the interesting things too, when it comes to progesterone, is the importance of potentially using an oral form of progesterone. When progesterone is broken down and metabolized through the liver, it makes a metabolite called allopregnanolone. This allopregnanolone is what is responsible for helping with sleep, helping with mood disturbances, helping with anxiety. And oftentimes I say, a lot of these patients will end up in their primary care provider's office complaining of a lot of these symptoms, and they'll get put on medications like SSRIs or anti-anxiety medications. But a lot of times it's really just a hormone imbalance that needs to be addressed. And we can do wonderful things with bioidentical hormones for these patients versus putting them on some other pharmacologic options. So next, getting into menopause. So this is really where we're seeing a lot of the ovarian follicular depletion happening. So we've got increased estrogen levels. We definitely have the loss of the negative feedback loop with regards to FSH. So as the estradiol levels are coming down, we are seeing the FSH levels increasing, and generally they are going to be over 30 on most lab work. And so that's going to be a good indicator that you've got a patient that is now in menopause. So, a true definition is 12 months without a period for a female patient, but then also looking at the lab work, again, we are seeing low levels of estradiol and increased levels of FSH. From a symptomatic standpoint, these patients have those vasomotor symptoms of the hot flashes, the night sweats, their urogenital atrophy, increased bone density loss, sleep and mood disturbances, cognitive changes. So, menopause is no longer viewed as just a natural phase that needs to be endured. We have options for symptom treatment. And again, remembering using those bioidentical hormones can, help with bone decay, the accelerated bone loss that women see due to estrogen depletion. The loss of estrogen also, again, has that cardiovascular shift that we talked about earlier, where we see rising LDL levels, stiffening of arteries, increased systemic inflammation. Then we also have that neurodegeneration. The brain's ability to burn glucose, interestingly, drops by about 25% during this time as well. So this increases the potential for, neurodegenerative diseases like Alzheimer's. So again, the rationale for starting these bioidentical hormones during this phase and helping to alleviate a lot of those symptoms is crucial for women's health overall and longevity. So next, the rationale for customizing a compounded hormone replacement therapy. So the wonderful thing about compounding is the personalization that we can do with dosages. Commercial products only come in a set of strengths and are generally only single ingredient options. With compounding, we can compound any strength product that the patient may need. We can put many different products all into one formulation for ease of use. It helps to aid compliance for the patient. And so this is definitely a key advantage over a lot of the commercial products that are out there. We also have lots of different options for delivery systems. We've got topical options in the form of creams and gels. This is definitely a preferred method for estrogen, again, because it does bypass first-pass metabolism through the liver, and we're not worried about those conjugates and those metabolites being formed that go down through more of the unsafe pathways with estrogen. This also helps to mitigate some of the risk that is seen over oral estrogens when it comes to blood clots and venous thromboembolism. We have options for oral capsules. This is often the preferred method, again, for progesterone that we talked about, because the metabolite of progesterone offers a sedative effect, which can help with sleep and mood and anxiety for a lot of patients. Also, the oral capsules of progesterone do confer endometrial protection against hyperplasia, which is very important, especially if you have a patient that is also utilizing estrogen as well. There are options for sublingual troches and drops. This has rapid absorption. It does bypass the liver. It can lead to high peak levels, though. It does have a short duration of action, but for some patients, this is a good option for them and the preferred delivery method. We also have vaginal preparations available. These are wonderful for local relief of genitourinary symptoms. And one of the wonderful things about a vaginal preparation is that we see very minimal, if no, systemic absorption from this. So this is a great option for patients potentially who have had issues such as breast cancer in the past or may have a familial history with breast cancer. Utilizing a vaginal preparation could potentially be a great option with resolving symptoms for those subset of patients. So some commonly compounded hormones, we've got estrogen, and there are 3 different types of estrogen that are out there. We have estradiol E2. This is the most potent estrogen, and this is often the one that is seen in commercially available products and is the most potent one that we use in our compounded products as well. We have estriol, which is E3. This is a weaker estrogen. It's often used in combination with estriol to form what we call a biased product. Estriol does have some anti-proliferative effects to it too. And that's why I often recommend combining the estriol and the estradiol together, especially when it comes to competing for receptor site binding, especially in breast tissue. Estriol can potentially confer some protection against proliferation in the breast tissue. And then we do have estrone. This is the primary estrogen that is formed after menopause. We see it a lot in being produced in the visceral fat. Estrone is not an ideal estrogen to use. It is definitely considered the most dangerous of the estrogens to use, and so it's not commonly compounded with. Progesterone, it's important to know that it does need to be micronized for adequate oral absorption. It is bioidentical to the endogenous progesterone that our body is producing. Testosterone is used for androgen deficiency in both men and women, so symptoms of low libido, fatigue, muscle loss. DHEA, again, that was one of the precursor hormones, if you remember back to the steroidogenesis pathway. So this can be converted into estrogen and testosterone. One of the things I love about DHEA is that it's really great at also supporting cortisol levels. So, cortisol, thyroid, sex hormones, there's a huge interplay between all of these hormones. And so, we can fix sex hormones, but we also have to make sure that we're looking at a patient from a cortisol and thyroid standpoint as well, and make sure everything is balanced in order to, maintain the optimal health for our patients. And lastly, we have Pregnenolone. So again, this is the mother of all hormones. It's a precursor to all of the other hormones. It's not used as often, but we do see its use somewhat in BHRT. So again, just another throwback to our steroidogenesis pathway after talking about all of those hormones, with pregnenolone being the mother hormone at the top and synthesized down into all of our progesterones, DHEA, testosterone, estrogens, cortisol. So first we're going to talk about estrogen and the influence that it has within the body, and so many different aspects to it: brain health, heart health, breast, liver, bones, ovaries, skin, uterus, you name it. We have estrogen receptors, obviously, throughout our body. And so again, this is why it's so important when we start to see estrogen levels declining in women and these symptoms of low estrogen start to creep in, that we start to address them, both from a symptomatic standpoint and also from a health and longevity standpoint. So the potential benefits of estrogen: from an immediate quality of life, we've got stability of the vasomotor symptoms, so supporting the management of the hot flashes and night sweats. Again, those genitourinary symptoms with the vaginal dryness, painful sex, vaginal atrophy, increased urinary tract infections. With sleep and mood, the benefits of estrogen, we do see an improvement in sleep by decreasing those hot flashes and night sweats, and it does also help to support serotonin and dopamine production, which can help stabilize mood. From a metabolic and physical health standpoint, it does help with insulin sensitivity and healthy fat distribution. We know that it does improve skin quality and thickness, helps to improve and increase collagen production within the skin, helps maintain muscle mass, and helps reduce joint aches that are commonly seen during the menopausal transition. And then with regards to long-term disease prevention, like we have talked about, we see the skeletal bone health. So inhibiting those osteoclasts, and those are the cells that break down the bones and help to maintain bone mineral density, decrease fractures. We've got the cardiovascular protection as well. So it helps to improve vasodilation and improve blood flow throughout the body. And then that neuroprotection, so supporting the brain with regards to glucose metabolism, and then also decreasing those beta amyloid plaques as well. Some of the potential benefits of progesterone are going to include endometrial protection. So we talked about how oral progesterone is really a key to helping with endometrial protection and preventing the hyperplasia that potentially can happen with estrogen replacement. We also see progesterone acting as a tumor suppressant and neutralizing the proliferative effects of estrogen. Also helps with bleeding. So again, during that perimenopause phase, for a lot of women that are seeing irregular menstrual cycles, progesterone can really help with that and maintain a stable, predictable uterine lining and help with a lot of that spotting that we'll start to see with those hormone fluctuations in perimenopause. Again, we know that progesterone is wonderful for brain health and sleep support through those sedative effects of the allopregnanolone metabolite. It does cross over into the blood-brain barrier and it binds to GABA receptors, helping to decrease anxiety, help to stabilize mood. It does also help to increase deep sleep. So unlike a lot of sleep medications, prescription drugs that are out there as well, the micronized progesterone really helps to increase that deep restorative sleep, which is so important. And again, addressing mood and anxiety as well. And then from a systemic standpoint, progesterone also does help with bone building. So while estrogen helps prevent bone loss, progesterone will help stimulate the osteoblasts, which are bone building in nature. So progesterone and estrogen really work synergistically together to help with overall bone health for women. Progesterone also helps with fluid balance too. So that's another thing that a lot of women who are going through perimenopause and menopause will report: a lot of bloating, weight gain around the midsection, water retention. And so progesterone can really help to balance out a lot of those effects too, acting as a natural diuretic. So it's very important to note, and going back to what we talked about earlier, contrasting the Women's Health Initiative and the oral hormones that were used there versus the bioidentical hormones that we use today, it's so important to realize that progestins are not the same as progesterone. And so here we'll go through quickly the difference between the two. So synthetic progestins are chemically modified to survive oral metabolism. However, progesterone, because it is bioidentical, we actually want it to be metabolized down into that allopregnanolone metabolite so that we get all of those wonderful benefits of sleep and mood stability from it. Synthetic progestins can also bind to androgen, glucocorticoid, mineralocorticoid receptors. And so that can have a lot of impacts on other systems throughout the body, whereas bioidentical progesterone will only bind to progesterone receptors, which is ideal. As far as breast cancer risk is concerned, synthetic progestins are linked to a higher risk, as was seen in the WHI trial when using medroxyprogesterone acetate, versus bioidentical progestin is actually linked to a lower risk in breast cancer versus the combined products of estrogen and progestins in the WHI. From a cardiovascular standpoint, synthetic progestins can blunt the effects of estrogen, the positive effects of estrogen on lipid profiles, whereas progesterone is generally considered neutral with regards to cardiovascular impact. So it doesn't negate the good HDL cholesterol, benefits of estrogen. On sleep and mood with synthetic progestins, a lot of patients were reporting mood swings, irritability, whereas again, with bioidentical progesterone, we know that it does have that calming and sedative side effect. From an endometrial standpoint, synthetic progestins are highly potent for thinning the uterine lining. If a patient is utilizing a synthetic progestin, it is often recommended to stop it if they are having heavy bleeding. However, with progesterone, we know that it does confer protection on the endometrial lining. And oftentimes progesterone is used to help stabilize patients that are having irregular bleeding. So next we're going to get into testosterone, and some of the causes for low testosterone can be stress and adrenal imbalance, hypothyroidism, increased age, nutrient deficiencies, and oral contraceptives can also have an impact on testosterone levels in female patients. So the potential benefits of testosterone, most of the time we always think of testosterone for its sexual health and helping with libido and desire. And it is the primary hormone responsible for that. It's also recognized as the gold standard for patients that have hypoactive sexual desire disorder. So we know that testosterone can drastically help improve libido. However, there are so many other wonderful benefits to it too. From a musculoskeletal standpoint of things, it does help with maintaining lean muscle mass in patients. We also know that it does aid in bone building as well, so maintaining those osteoclasts. It does contribute to a higher basal metabolic rate. So for patients that are looking for assistance with weight control, we know that testosterone can be a huge benefit there. And again, working synergistically with estrogen on bone density. Cognitive and psychosocial well-being. Women who are on testosterone report increased mental clarity, improvements in focus and verbal memory, definitely an increase in energy levels and drive. It's essential for, motivation, reducing fatigue as well, and mood stability. Low levels of testosterone are linked to irritability and anxiety. So again, I think it's so important to make sure that we are looking at women who are reporting issues with low libido, low energy, fatigue. We're looking at these levels of testosterone as early as possible, even in patients in their 30s. And as we saw on the previous slide, a lot of these patients who may be on oral contraceptives could potentially have low levels of testosterone. So important to remember that we're not just talking about menopausal women when we're talking about hormone fluctuations. We're talking about a wide age range of patients here. So it's also important to note some of the possible side effects of hormones when we're talking about women's health and starting any type of bioidentical hormone replacement protocol. So when it comes to estrogen, and these are typically dose-dependent side effects that we see, oftentimes with starting, breast tenderness can be very common. And this is often a sign that the dose potentially can be too high or was increased too quickly. One of the beauties with compounded products is that dosage adjustments can be made very easily to the hormones. So if a patient comes back to you with reports of side effects on these, again, easy to adjust up or down as needed. Bloating and fluid retention can be another side effect of estrogen. Estrogen does cause the body to retain some sodium and water. Oftentimes, like we said, this can be balanced out by utilizing some progesterone alongside of it. Nausea is a common side effect, but it's more common with the oral dosage forms versus the topicals that we see in our compounded BHRT products. Headaches and migraines. Sometimes estrogen can be a hormone trigger for some women. It's not very common, but something to keep in mind. Generally speaking, though, BHRT does reduce migraines over time for most patients, so a good option for symptom relief from headaches and migraines. And then with estrogen, sometimes bleeding or spotting can be common within the first few months until hormone levels do begin to stabilize. With progesterone, we do see drowsiness and sedation as a side effect with progesterone. Often this is a positive side effect for patients who are having sleep disturbances or mood disturbances. But it's usually resolved by taking the progesterone at bedtime. However, for some patients, this can be debilitating. And so there are other options for utilizing progesterone if they're unable to take the oral dosage form, if there is too much drowsiness. Vaginal and topical preparations are also available. For some women, in a small percentage, depressive symptoms can be a side effect of progesterone as well. Vivid dreams can occur. This happens because women tend to spend more time in that deep restorative REM sleep, and those will usually dissipate over time as the body adjusts to the levels of progesterone and builds up to a steady state. And then sometimes breast swelling can be another side effect of utilizing progesterone, and can contribute to the tenderness that is seen with utilizing estrogen replacement therapy as well. Again, most of these symptoms do dissipate over time for most women, but again, the beauty of custom compounded hormones is that dosages can always be adjusted as needed based off of patient symptoms. And then finally, with testosterone, sometimes we will see changes in skin, oiliness, acne can occur, increased hair growth is a potential as well. Irritability can happen if the dose goes too high, and sometimes some voice changes. And these are extremely rare. But again, all of these side effects can be mitigated with dosage adjustments. And again, that's the beauty that we see with custom compounded hormones. So that's all we have for you today. Thanks again for joining us on this Strive Sessions where we talked about women's health and bioidentical hormone replacement therapy. Stick around for our live Q&A, and please make sure to drop any questions that you have in our live chat. If you have any unanswered questions after this, feel free to reach out to your Strive rep and we'll make sure we get any questions you have answered.